Hello. 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 Is this working? Check, sir. Talking. Hello. Very fantastic evening. Am I audible? Okay, it's okay. Yeah, good. So, very fantastic evening to my dear students. A warm welcome to Medskool Pharmacology. Okay, I'm very happy and super excited to see you all in your YouTube session. Okay, so today we're going to discuss one small topic, quite interesting topic, anti-Parkinson drugs. Like a cinema movie, we are going to discuss for 1 hour. I think you're all going to enjoy the show. So listen, enjoy, and give your comments at the end of the session. Okay, we start like a movie. Okay, so for understanding anti-Parkinson drug, we have to understand the fundamental. The fundamental is dopamine as a neurotransmitter. Okay. Sorry, Dr. Iris Gauda, stuck. You just reconnect, Doctor. It will be working. Just reconnect. We start our discussion. Listen and enjoy. For understanding anti-Parkinson drug, we should know the basic dopamine as a neurotransmitter in the brain. What are the fundamental? Look here. In the brain, there are three important pathways you should know for understanding this. One is mesolimbic pathway. Another one is nigrostriatal neuron pathway. And another one is tuberoinfundibular pathway. Okay, now we start. I go from the fundamental. You can enjoy as a first year student, second year student, medicine, even post MD. We are all going to benefit by this session. First, we start with the mesolimbic fiber. Look here. The mesolimbic fiber extending up to the prefrontal lobe. This mesolimbic fiber going to secrete dopamine as a neurotransmitter in the prefrontal lobe. This dopamine plays a major role in controlling behavior. So the function of dopamine in prefrontal lobe is controlling behavior. So whenever there is an overaction of dopamine, it causes abnormal behavior in the form of psychosis. So the most important neurotransmitter defect that causing psychosis or overaction of dopamine. This resulting in illusion, delusion, hallucination, symptoms of psychosis. So it's a point one, overaction of dopamine in prefrontal causing psychosis. Another fundamental physiology, look at the black color fiber. It is called nigrostriatal neuron. It is the most important for today's session. Why it is called nigrostriatal neuron? See, the neuron starting from substantia nigra ending in corpus striatum. That's why it's called as nigrostriatal neuron. What is the function of this neuron? This neuron causes synthesizing, storing, and releasing dopamine as a neurotransmitter in the striatum. So, nigrostriatal fiber releasing dopamine in the striatum. Physiology. What is the function of dopamine in the corpus striatum? The dopamine initiate movements. Suppose if I want to walk, if I want to swim my arm, the initiation done by dopamine in this striatum. But you should know, in the striatum, we not only having dopamine, we also have some other neurotransmitter like acetylcholine. So, what physiology book says, in the corpus striatum, we have balanced amount of ACH and dopamine. Look at the fundamental. In the basal ganglia, we have balanced amount of acetylcholine and dopamine. See, I am discussing dopamine initiating movements, whereas you may be studying physiology. Acetylcholine in the muscle causing muscle contraction. Now think clinically, as age advances, this neuron may go for degeneration. When they go for degeneration, it may not be able to synthesize, store, and release adequate amount of dopamine. When dopamine not released adequately, the balance get disturbed. Going to be deficiency of dopamine with relatively overaction of acetylcholine going to happen. Now think clinically, deficiency dopamine that causes reduction of movements called hypokinesia. Overaction causing of acetylcholine causing contraction causing rigidity and tremor. Look at this patient having hypokinesia, rigidity and tremor. These are symptoms of Parkinson disorder. So question, in Parkinson disorder, hypokinesia due to deficiency of dopamine. The rigidity and tremor are due to overaction of acetylcholine. It is the pathology. That means, as a beginner, come on, for treating Parkinson disorder, we have two classes of drugs. One group of drugs that are going to increase in dopamine level. The other group is going to antagonize acetylcholine level. It is the fundamental. Are you able to understand? Come on, I need a feedback before going to another fundamental. Can you answer? Are you able to follow? Look, the next basic is, look here. We have one more fiber called tuberoinfundibular. This fiber extends from hypothalamus to anterior pituitary. Now look at the point. What is the physiology of this fiber? This fiber releasing dopamine as a transmitter in the anterior pituitary. Now question starts. What is the function of dopamine in the pituitary? Dopamine control inhibiting prolactin secretion. It is physiology. Now question to all people. Can you please answer? Suppose a lady having galactoria, increased milk secretion. When I do MRI, I came to know she is having pituitary adenoma. A tumor releasing large amount of prolactin called prolactinoma. So now question to all people, please answer. In the treatment of galactoria, in the treatment of prolactinoma, I have to suppress prolactin. For that, the treatment is I have to go for dopamine agonist. Because dopamine going to control the release of prolactin. So dopamine analog like bromocriptine, cabergoline, very good. Shravam, Kasma, very fantastic. Divya, fantastic. So dopamine agonist like bromocriptine, cabergoline, useful for treatment of galactoria. And before going to main point, look at the point. Look at the fundamental. So this patient having hypokinesia, rigidity and tremor. I know diagnosis Parkinson. In this Parkinson, I know the problems are one, dopamine deficiency. Second, overaction of acetylcholine causing muscle rigidity and contraction. So my question, for treating Parkinsonism, I have to increase dopamine. For example, if I give levodopa, levodopa is a pro-drug of dopamine. I'm going to give. This will crosses the blood-brain barrier, goes to brain. In the brain, it will become dopamine. When become dopamine, it's going to improve walking capacity. Now, question to all people: can you interact? Even in YouTube channel, you should interact me. Come on. Suppose if I keep on giving levodopa with carbidopa, if I keep on giving, there will be increased amount of dopamine formation happening in prefrontal lobe. Sometimes increased dopamine in stratum also. Can you please answer? On chronic therapy, levodopa causing what adverse effect? When you give dopaminergic drug on chronic therapy, there could be increased dopamine in prefrontal causing what? Overaction of dopamine causing what? Psychosis. Whereas overaction of dopamine in the stratum. In the stratum, dopamine initiating movements. When overaction causes abnormal movements called choreoathetotic. So, the adverse effect of dopaminergic drugs on long-term therapy includes number one, psychosis, number two, abnormal movements called dyskinesia, choreoathetoid movements. So remember, on long-term therapy, dopaminergic drug will cause two central adverse effects. One is psychosis, one more thing called choreoathetoid movements. With this introduction, today I am going to start my topic of anti-Parkinson. See here, everybody says pharmacology tough. That is because they don't understand the concept. If we understand the fundamental pharmacology, lovely subject, you can enjoy it. Okay, so now we go for discussion. First, the most wonderful drug useful for treating this case is levodopa. Come on. As a second year for UG examination, as an intern for PG entrance examination, look at the point. Levodopa, point 1. It's a pro-drug of dopamine. Why we have to give levodopa? Why not dopamine? Dopamine will not cross blood-brain barrier. So we give levodopa. Okay, when I give levodopa, what happens? When levodopa taken orally, the levodopa goes to GIT. Imagine it is intestine. My question starts. When levodopa goes to intestine, the levodopa getting absorption. Now the question. It get absorbed into the circulation. The question is, absorption of levodopa is through one amino acid transporter. Look at one. Levodopa absorption is via one amino acid transporter. Now question starts. When levodopa absorbed via amino acid transporter mean, suppose if a patient is taking levodopa with the protein meals. Please look at me. The protein meals are made up of amino acid. Now question goes to all my dear friends. Can you please answer? When levodopa taken with the protein meals, the dietary amino acids also competing for absorption. In this absorption, levodopa absorption can be interfered. That means today one point. First MCQ point, please note, protein meals will decreases absorption of levodopa. It is first MCQ point. So question, levodopa should not be given with which type of food item? Answer, protein food item. It's called drug-food interaction. So first MCQ over. Next question. Look at me. When levodopa get absorbed, listen to the photo. When levodopa get absorbed, it enter into circulation. Imagine, look at me. Imagine it is the peripheral circulation. Now question starts. When levodopa absorbed into circulation, imagine it's the brain. Here is the blood-brain barrier. Okay. and it is the intestine. It is the intestine. Now question starts. When levodopa absorbed goes circulation. Here the levodopa by the help of peripheral dopa decarboxylase enzyme converted into dopamine. So levodopa converted into dopamine in the periphery. That is before crossing the blood-brain barrier. Majority levodopa become dopamine in periphery. Because of this, what is the drawback? One of the disadvantage, less amount of levodopa goes to brain. And one more disadvantage, if large amount of dopamine formed in periphery mean it causes toxicity. So question 1. The two important disadvantage of giving levodopa alone. Look at the concept. When I give levodopa alone, two problems. One, poor bioavailability. Less amount of drug will goes to brain. Second point, there will be peripheral toxicity, peripheral adverse effect. So the two major disadvantage of giving levodopa alone includes less amount of drug goes to brain and large amount of peripheral toxicity. Now question starts. When you say peripheral toxicity, I want to know what are the important peripheral adverse effect of levodopa. Please follow me. When you say peripheral toxicity, before that, one super interesting question. Look at me. Pyridoxine between B6. My question starts. Suppose a patient taking levodopa with pyridoxine with B6. What happened? Very important question. Pyridoxine, it is stimulant. It is stimulant of dopa decarboxylase. So pyridoxine stimulating this enzyme, thereby all the levodopa easily become dopamine periphery. So the amount of drug goes to brain will be less. That means please remember the two problem. One, I told in the beginning, can you please repeat? Which is the food that should not be given with the levodopa? One is protein. Next question. Which is the vitamin that should not be given with the levodopa? Answer B6. Pyridoxine. So B6 levodopa should not taken together because B6 is the stimulant of dopa decarboxylase. Thereby levodopa can become dopamine in periphery. So be careful. Be careful. Now coming next point. I want to know what are the peripheral adverse effect of levodopa. Please follow me. The peripheral toxicity. Look here. The peripherally formed dopamine may act on CTZ. Look here. Vomiting center not covered by barrier. So the peripheral dopamine acting on vomiting center, stimulating the D2 causes nausea, vomiting, and alteration of taste sensation. So the most common adverse effects levodopa causes nausea, vomiting, altered taste sensation. Now the questions to all people, can you please interact with me? Patient is taking levodopa improving walking capacity but causing nausea, vomiting. So can you please answer? To control this nausea and vomiting, I want to give some anti-emetic agent. Can you please answer? For controlling vomiting due to levodopa, what is the best anti-emetic? See, vomiting here is due to stimulation of D2. So I have some D2 blocking anti-emetic like domperidone and metoclopramide. See, both are D2 blocking anti-emetic. But question to all people, among the two, which should be given, which should not be given? Don't use metoclopramide. Note, don't use this because metoclopramide will crosses the blood-brain barrier and reduces the efficacy of levodopa. So, without compromising efficacy of levodopa, only for controlling vomiting, I need a drug that should act only on periphery, that should not crosses the blood-brain barrier. So here, domperidone, a D2 blocker, blocking D2 only in the vomiting center. It is not crossing the blood-brain barrier. So the best anti-emetic, domperidone. Don't use metoclopramide because metoclopramide will cross the barrier, reducing efficacy of levodopa. Okay, next question. We are discussing peripheral adverse effect. One is GI toxicity like nausea, vomiting. Other problem, look at the peripherally formed dopamine act on myocardium. By acting on myocardium, it causes tachycardia, sometimes palpitation, sometimes causing angina. My question starts. How can a peripheral dopamine causing this problem? Look here, thus you should know. Dopamine actually in periphery acting on D1, beta 1 and alpha 1 receptor. By acting on beta 1 in the heart, it causes palpitation, sometimes angina. It's called cardiotoxicity. Last point for good medical men, one interesting point. Look here, when they keep on giving levodopa, there will be too much of dopamine in periphery. It may cause sometimes reduction of central vasomotor outflow. It may rarely cause postural hypotension. So another rare problem, postural hypotension because of reduction of central vasomotor outflow. These are peripheral toxicity. Now the question starts. All these peripheral adverse effects are due to formation of dopamine in periphery. So my dear friends, to avoid all this toxicity, what can be done? We can do one thing. We can inhibit peripheral dopa decarboxylase enzyme. When we inhibit this enzyme, we can minimize formation of dopamine in periphery. So usually in practice we give levodopa along with peripheral dopa decarboxylase inhibitor. Now can you please answer? Name some example for peripheral dopa decarboxylase inhibitor. For example, we have carbidopa or we have benzerazide. So the two examples for peripheral dopa decarboxylase enzyme blockers are carbidopa, one more drug, benzerazide. Now go to the next point. Hereafter, when you give carbidopa and levodopa together, what is going to happen? Now look at the point. In practice, we give levodopa with carbidopa. Question starts. What is the ratio? See, levodopa 100 mg, carbidopa 25 mg. That means 4:1 ratio. It is also old MCQ. What is the ratio? 4:1 ratio. Now the question starts. When I give levodopa with carbidopa, what is the advantage? One of the advantage, I can get large amount of levodopa goes to brain. That means increasing bioavailability of levodopa in the brain. 1 point. Second advantage, I can decrease peripheral formation of dopamine. Thereby, I can reduce peripheral adverse effect. So the two most important advantage, I can have increased bioavailability and decreased peripheral toxicity. This advantage. But one question, come on. If we keep on give levodopa, carbidopa together for longer duration on chronic therapy, if too much of levodopa goes to brain main, if this will become dopamine in the brain. If there is too much of dopamine in prefrontal, it may cause psychosis. If too much dopamine in corpus stratum, it causes abnormal chorioathetoid movements. So the long-term adverse effect, delayed adverse effect of levodopa plus carbidopa includes CNS, central adverse effect like psychosis and also chorioathetoid movements. It's so remember the carbidopa going to control only the peripheral adverse effect. In fact, central adverse effect going to get increased. Another very important point you should know. When you think of Parkinson disorder is a neurodegenerative disorder. Because of day by day degeneration, there may not be adequate dopamine in the brain. So when you keep on giving levodopa, what happens? When you give levodopa, when you start giving, there will be good response. There will be good amount of walking. But as the time pass, when the levodopa level get decreases, there will be slow movements, aggravation of Parkinson, called on and off phenomena. See, one of the problem in Parkinson on and off, because the degeneration is very fast. Because of faster degeneration of neuron, my drug, when I start the drug, good amount of movements, they're called on, and make it abnormal movements. And time passes, when drug level falls, it causes off. Off means severe hypokinesia, not able to walk. Called on-off phenomena. Here, when they go for off means severe hypokinesia. When they go for hypokinesia, they're not able to walk, not able to move, become bedridden. When bedridden, developing bed sores, abscess, infection, septicemia. So my question, to control this along with the levodopa, I give some adjuvants. MCQ starts. Can you please answer? Name some adjuvants that can be used with the levodopa to overcome the off phenomena. What are the drugs useful for managing off? For example, we can go for entacapone, opicapone from COMT blocker. Entacapone, opicapone are COMT blocker. Then selegiline, a mono amino oxide B blocker. Or else one new drug, one latest drug called histodifilin. It is the A2. A2 means adenosine antagonist. The latest MCQ. Name the adenosine antagonist having role in the treatment of Parkinson. Answer is histodifilin. And if these drugs not giving adequate response, mean the last option we want thing called apomorphine. It's a rescue. Very important. Apomorphine is an injection given subcutaneous injection. It's a D4 agonist. It is a rescue. That means last option. Don't go initial this because it is highly toxic drug. It causes adverse effect of severe vomiting, severe QT prolongation. So the last option, rescue therapy, apomorphine. Very good, Ankit. Fantastically answering. Good. And also Shama Rathiria. Good, fantastic. So we have something adjuvant therapy to overcome off phenomena. Okay, and last but not least, the most important, we so far discussed levodopa as a monotherapy, levodopa plus carbidopa as a combination. I think 25 to 30% fundamental and the beginning over. So far, are you able to follow that? If you are good, if you are understanding, enjoy my next session called D2 agonist. For treating Parkinson disorder, we have another group of drug called D2 agonist. For example, there are two classes of drug. One is ergot D2 agonist. One more thing, non-ergot D2. D2 means dopaminergic agonist. So I go one by one. My first class will be ergot D2. First, I should know what are the examples. The example for ergot D2 agonist are number one, bromocriptine. Number two, pergolide. Number three, cabergoline. Bromocriptine, pergolide, and cabergoline. First question. All these are ergots. If a drug is ergot, they may cause adverse effect of vasoconstriction. Now question starts. Because of vasoconstriction, they may reduce blood supply to lower limb. Thereby, patient may complain of pain on walking. Initially, limb become red in color. Later on, gangrene black in color. Because of pain and redness, we name this area as erythromelalgia. So, one of the adverse effect of ergot D2 agonist, erythromelalgia. Erythro mean redness, melalgia mean pain on walking. Another problem, all these three drugs may cause adverse effect of cardiac valve fibrosis. Here, please underline pergolide. It is the one causing maximum risk of cardiac valve fibrosis. So the two problem, one is peripheral vasoconstriction, second thing cardiac valve fibrosis. Now another interesting point, look here, the bromocriptine cabergoline, wonderful drug. Here I just go for first bromocriptine. Question starts. Bromocriptine, we know a D2 agonist. Because of D2 agonist is useful for Parkinson. Can you please answer somebody? As a D2 agonist, other than Parkinson disorder, it is also useful for what? It is also useful for treatment of other condition like we know useful for Parkinson disorder. Other thing, useful for controlling galactoria, useful for prolactinoma. So uses of bromocriptine, important area for MCQ. Remember, one use useful for Parkinson, second thing useful for prolactinoma. Third point, bromocriptine decreases growth hormone release from pituitary. Because of this action can be useful for treatment of acromegaly. One more point, doctor, it got approval for treatment of type 2 diabetes. Mechanism not known. They say maybe decreasing appetite, but exact mechanism not known, but it's approved drug for treatment of type 2 diabetes, and it is also useful for managing neuroleptic malignant syndrome. See, it is one of the adverse effect of D2 blocker. It's one type of EPS. Okay. Now question starts. Anybody? What is the drug of choice? What is the drug of choice for treating this case? Originally, for treating this case, drug of choice is dandrolin. Please note, dandrolin. It is one of the directly acting skeletal muscle relaxant. It's a directly acting SMR. Along with dandrolin, adjuvantly we can give bromocriptine. Bromocriptine is a supportive, it's an adjuvant. So the main drug of choice for treatment of malignant neuroleptic syndrome, dandrolin. So far we done ergot D2. Now going to non-ergot. Now next point, non-ergot D2. First I should know example. Please follow me. The non-ergot D2 agonist drug names are pipexole, ropinirole, rotigotine. Example for non-ergot D2 agonist, pipexole, ropinirole, rotigotine. First question, advantage. Since non-ergot, one of the greatest advantage, no risk of vasospasm. That's a great advantage. Another thing, MCQ, all this among this underline the rotigotine special. Please note the rotigotine can be given topically, transcranial patch, transdermal patch. So name the topically useful drug for treating Parkinson. Answer rotigotine. Then the pipexole special point, it has additionally antioxidant activity also. This is special point. Now coming to point. This is a wonderful drug for treating Parkinson. We know what is the adverse effect. On chronic therapy, remember all are D2 agonists. Can you please answer? Because of deep dopamine agonism, on chronic therapy, it causes what adverse effect? When too much of dopamine formed in the brain mean risk of psychosis. So one of the most important area causing psychosis. Here also, what is the clinical symptom of this psychosis? See, normally in psychosis, they have illusion, delusion, hallucination. But here, compulsive behavior. Compulsively, I want to go for shopping. Today, Monday, traffic jam. I want to go for shopping. They adamantly say compulsive behavior. And in shopping also, stealing some object called kleptomania. Unnecessarily stealing something. And one more thing, excess interest on sex. Increased sexual desire. See, problem. Already patient Parkinsonism, not able to stand, not able to walk. If this occur, what happened? Don't think too much. It's their problem. You live it. So anyway, remember one of the problem causing excess interest on sex called sexual desire. But again, very important point, actor. You know these three drugs are wonderful drugs for treatment of Parkinson disorder. But you should know they also useful for. Can you please answer? What is the other important use? The other use is these three drugs are got approval for treatment of restless leg syndrome. Important. Useful for treatment of restless leg syndrome. So, Prepexol, rotigotine, ropinirole are approved drug for treatment of restless leg syndrome. In this condition, you should know one new point. See, we have one drug called gabapentin enacarbil. It's a newer drug. This is a pro-drug government. It is also got approval. It is also approved for treatment of restless leg syndrome. So remember, doctor, usually for treatment of restless leg syndrome, first option will be D2 agonist like pramipexole, ropinirole, rotigotine. What else can useful be? Think of gabapentin enacarbil. It's a pro-drug gabapentin. It's also got approval for treatment of restless leg syndrome. So far we done D2 agonist. Next, another group of drug useful for treating Parkinson, amantadine. Only 3 points. First point, amantadine is an antiviral drug. Actually useful only for influenza A virus. We have influenza A virus, B virus, but here amantadine in antiviral drug useful only for A, not for B. But this is an antiviral drug, but has some wonderful action on CNS. It is antiviral action. The other actions are they have anticholinergic, dopaminergic agonism, and NMDA antagonism. Because of these other action, amantadine also useful for treatment of Parkinson disorder. So question can be, name the antiviral drug useful for treating Parkinson disorder. Answer, amantadine. Question number 2. When they give amantadine, what will be the important adverse effect? The two important adverse effects of amantadine are 1. Ankle edema and libido reticularis. Ankle edema, swelling in ankle, okay. Libido, MCQ, it's called net-like skin rashes. Look at the leg. It's a net-like skin rashes. It's a typical adverse effect caused by amantadine. So MCQ, they may give this image and they're asking image-based MCQ. It's a picture of one adverse effect caused by dash and drug useful in Parkinson. Amantadine, a anti-Parkinson drug causing libido reticularis. Okay. Next, the another group of drug useful for treating Parkinson disorders are COMT blocker, catechol O methyl transferase inhibitors. The examples are we are in entacapone, tolcapone, and one newer drug called opicapone. So there are 3 important examples for COMT, catechol O methyl transferase enzyme blocker, entacapone, tolcapone, opicapone. All the 3 drugs useful for treating Parkinson. Here MCQ, the opicapone, entacapone, in addition to Parkinson, also got approved for treatment of all phenomena in Parkinson. But another interesting question. Among the 3 drugs, note down this. It is the most dangerous. So you should know what are the important adverse effects of COMT blocker. Come on. It causes adverse effects of number 1, rhabdomyolysis, severe diarrhea, and severe hepatotoxicity. Remember, it causes severe hepatotoxicity. Because of that, it is not used commonly. We don't use. And one more point, doctor, rhabdomyolysis. Myo mean muscle. When muscle is lysed, there's a muscle break. When the muscle broken, from the muscle, release of myoglobin. When myoglobin released, it will goes through urine and causing myoglobinuria, thereby urine discolored into yellowish orange. So question can be, which is the drug useful in Parkinson causes adverse effect of yellowish orange color urine. Answer tolcapone because of rhabdomyolysis. The another group of drug useful in Parkinson we go for monoamino oxidase B. Monoamino oxidase B enzyme blocker. Drug name important. One is sertraline. Next is rasagiline, and the latest newer drug sulfonamide. So examples for MAO-B blocker, sertraline, rasagiline, and sulfonamide. In this, most commonly used is sertraline. Here MCQ1, it has antioxidant property, also useful for treating Parkinson younger patients. One more point, when I say antioxidant, it's a wonderful point. Why? Because see, actually Parkinson disorder, a neurodegenerative disorder occurring in old age. But sometimes a toxin, there are some toxin, neurotoxin causing Parkinson called MPTP. MPTP, what is? It's a methyl phenyl tetrahydropyrene. It is one of the toxin causes problem of nigrostriatal neuron causing oxidative stress resulting in Parkinson. So to control toxin induced Parkinson also we can try this, useful for treatment of toxin induced Parkinson. And extra point, so we know useful for treating Parkinson. Extra point, it is also available as a transdermal patch for treating depression. So extra point actually, it is actually useful for Parkinson. Extra point, it is also available as a patch for treatment of depression. But extra point, adverse effect. What is adverse effect? The sertraline going to produces one metabolite called amphetamine. Amphetamine is the metabolite of sertraline. Amphetamine CNS stimulant. Now question starts. When I give sertraline, it's going to form amphetamine in the brain, causes insomnia, anxiety. So adverse effect of sertraline may cause central nervous system stimulant effect like anxiety, insomnia. That's about MAO-B inhibitor. Again, one question after, whenever you talk about MAO blocker, you should know any patient on MAO blocker, when they take thiamine containing food item like cheese or wine, they may develop severe hypertension called cheese reaction. And another point actually, whenever you give MAO blocker along with SSRI or TCA, there will be too much of accumulation of serotonin, that is called serotonin syndrome. So MAO blocker drug interaction important. They cause cheese reaction problem when taken with the thiamine food item. Another point, when they take with the SSRI or TCA, too much of accumulation of serotonin causing serotonin syndrome also possibility. That's about MAO-B blocker. And finally, we done levodopa, carbidopa, then dopaminergic agonist, ergot, non-ergot, and then COMT blocker, and finally MAO-B blocker. And last question, look here. There are some drugs, see, antipsychotic drug. D2 blocking antipsychotic. They call typical antipsychotics, or some D2 blocking antiemetic like metoclopramide. They are not going to cross the blood-brain barrier, and they going to cause adverse effect of Parkinson. It is called drug-induced Parkinson. So there are some drug inducing, precipitating, causing Parkinson. Called drug-induced Parkinson is one type of EPS. Now, which are all the group of drug causing extra pyramidal symptom? Like drug-induced Parkinson means D2 blocking antipsychotic like haloperidol, clopramazine, or D2 blocking antiemetic like metoclopramide. Now question starts. For treating this drug-induced Parkinsonism, can you please answer what the best treatment for this case? Option A, can you go for dopamine agonist or you go for anticholinergic. What is the best for treating this case? Option A, go for dopamine agonist or go for anticholinergic. What is best? If we go for dopamine agonist, it's going to worsen psychosis, so it's not good. So for treating drug-induced Parkinson disorder, the best is centrally acting anticholinergic. For treatment of drug-induced Parkinson, for treating this case, treatment is centrally acting anticholinergic like trihexyphenidyl, trade name benzexol, or else we can go for some other anticholinergic. All these are centrally acting anticholinergic like trihexyphenidyl, the so-called benzexol, or we can go for benztropine, biperidine, procyclidine. All are centrally acting anticholinergic. Or once again, if this option not given, we can also try one thing called promethazine. Come on, promethazine. Promethazine, actually a first generation antihistamine, has high amount of central anticholinergic action. So this is also having high amount of central anticholinergic action. So this is also useful. So remember, for treating drug-induced Parkinsonism, the best choice will be centrally acting anticholinergics like trihexyphenidyl, or we can go for benztropine, or we can go for biperidone, procyclidine, or else we can also go for promethazine. Okay, right. Now we done routine Parkinson, drug-induced Parkinson. My next question, very interesting question. Look here. This patient is a Parkinson disorder patient. For treating this case, if I give dopaminergic drug, like levodopa, or if I give pramipexole, or if I give rotigotine, all are dopaminergic. Can you please answer, my students? When you keep on giving dopaminergic drug for treating Parkinson, if there's too much of dopamine formed in the brain main, so if there's too much of dopamine formed in brain main, it causes adverse effect of psychosis. So your anti-Parkinson drug causing psychosis, that's called PDP. That's called Parkinson disease psychosis. So Parkinson patient, because of anti-Parkinson drug therapy, developing psychosis, that is called PDP, Parkinson disease psychosis. Now question starts. For treating this psychosis, can you please answer? Patient is a known case. It's a known case of Parkinson patient. Because of treatment developing psychosis, we call this PDP. My question starts. For treating this psychosis, will you go for T2 blocking antipsychotic? Can you please answer? Will you go for this? Patient is known Parkinson, treated by anti-Parkinson drug, developed psychosis. For treating this case, will you go for antipsychotic like D2 blocker? No, if you go for D2 blocker, they may worsen Parkinson disease. So for treating this psychosis, I go for atypical antipsychotic. For treating this, I go for atypical antipsychotic like clozapine or quetiapine. So for treating Parkinson disease psychosis, for this psychosis, I go for clozapine or quetiapine. But latest point, somebody mentioning latest point, we have one thing called pimavanserin, a fantastic FDA approved new drug. It is a FDA approved drug useful for treatment of PDP. What is pimavanserin? It's a 5:2A inverse agonist. So 5:2A inverse agonist useful for treatment Parkinson disease psychosis. Drug name pimavanserin, 5:2A inverse agonist. Okay, doctor. So far we did the fundamental dopamine as a neurotransmitter. Next we discuss dopaminergic drug for treatment of Parkinson. Then we discuss about drug-induced Parkinson treatment. Later on, we discuss about Parkinson disease psychosis treatment. So, in summary, what we discussed so far includes for treating Parkinson disorder, we go for either levodopa, carbidopa, or we go for dopamine agonists like ergot, non-ergot, and these are wonderful drugs because no peripheral vasospasm. Very good, very good. And then we also have amantadine, an antiviral drug, and then we discuss about MAO B blocker, where selagelin is a wonderful drug having antioxidant activity. And finally, we discuss also COMT blocker like tolcapone, entacapone, opicapone, and we also finish about drug therapy for treatment of drug-induced Parkinson, that is centrally acting anticholinergic. If you are comfortable with this, if you understand, if you enjoy, try to show your talents. I'm going to show some MCQ, try to answer. So we discuss centrally acting anticholinergic like benzhexol, the so-called trihexyphenidyl, benztropine, procyclidine, bipedin, all are wonderful drug for treatment of drug-induced, useful for treatment of drug-induced Parkinson disorder. All these things we revised. Now time to revise your memories. So whatever we discussed for the past 52 minutes, shall we go for revision? Come on, answer. In this revision, if you answer, I will be happy. Come on, revise. In basal ganglia, dopaminergic activity balanced by dash. I told in basal ganglia there's a balance between dash and dash, dopamine and dash. Can you make it fast answer? Answer B. Very good. Acetylcholine. Fantastic. Smarts. Very good. Very good. Very good. Question number 2. Ready? Question number 2. Which of the following is contraindicated with levodopa? Which of following contraindicated? I told one thing should never given with the levodopa. What is that? Answer B complex, especially B6, vitamin B6, pyridoxine. It is stimulant of DOPA, peripheral DOPA decarboxylase, should never given. Okay. Next question. All of the following statements regarding levodopa are correct except, I want except, can I answer? Except. Regarding levodopa, all are correct except protein will decrease absorption. Yes. It's a prodrug. Yes. Pyridoxine reducing efficacy. Yes. Now look at it. Domperidone blocks levodopa induced vomiting and its therapeutic potential. No. Domperidone control only vomiting. This don't compromise efficacy. Whereas metoclopramide, remember metoclopramide, that is the one reducing efficacy. That's why I told that is should not used with levodopa. Answer D. Very good. Next, drug of choice for treatment of drug-induced Parkinson. Answer drug of choice. Options are question drug-induced Parkinson. For this, among this given option, what is best answer? Benzhexol. It is a centrally acting anticholinergic agent. That's best option. Okay, good. All are answered nicely. Fantastic. Good. Now, a clinical question. Can you try? A 70-year-old patient with the Parkinson presenting with a swollen foot, redness, tenderness, and very painful. The symptom would be abate within few days if the patient stops taking what? Patient having swollen foot, ankle edema, redness, pain on walking, symptoms of erythromelalgia, adverse effect, ergot. Answer very fantastic. Answer bromocriptine. Good man, good, fantastic. Now, can you go for this INICET type of question, matching type of question? Here, I given some options. Try. I given some option and treatment. Ready? Haloperidol induced abnormal movement treated with. See, haloperidol, a D2 blocking antipsychotic. It causes EPS. For treating this EPS, the answer is trihexyphenidyl. One means C. Okay. Next, contraindicated levodopa. Answer pyridoxine. 2 mean A. Cardiac wall problem seen with pergolide. 3 mean C. Restless leg syndrome treated with rotigotine. So 4 mean B. Answer? Yeah, beautiful man. Answering nicely. Fantastic. Fantastic. Look. Highly, I give it property and responsible. Can you answer? Highly hepatotoxic among the given option. The answer is uh, tolcapone. Tolcapone is COMT blocker, highly hepatotoxic, not in use. Transdermal patch, rotigotine. Rotigotine is a patch form for treatment of Parkinson. So 1 mean D, 2 mean A. Rescue for off phenomena, apomorphine injection, subcutaneous apomorphine. It's a D4 agonist. So 3 mean answer B. An antiviral amantine. Yeah, antiviral drug useful for treating Parkinson, amantine. Okay, I think everybody answering fantastically, amazingly. I feel happy to teach you. I feel proud to teach you. Okay, so fantastic response. Okay, and the last but not the least, if you are enjoyed, if you're satisfied, if you feel happy, so like your YouTube channel, we also become, so like, share, subscribe, come on, comment on the box. We have eMedicos app, we have eMedicos Telegram channel, we have DAMS YouTube channel. So we have a lot of platform for you people. You can enjoy like anything. So I'm damn sure that if we have studied the class notes material and discussion material in eMedicos and T&D paper and lot of MCQs with the discussion with the live, video discussion, if we solve all the problem, you will be master. I am damn sure you become master. Okay, so when a single shot, you are going to get a very good seat in your PG examination. So nothing is impossible, man. You can do anything. Okay, so do hard work and do sincerely, consistently hard work. You become master. So like, share and subscribe, and please click on the icon button for further notification. Okay, so may God bless you all, the very best. Thank you for the great opportunity, and if you have any doubts, you feel free to ask. Now it's time. If we have no doubts, we close the session. Once again, like, comment, share and subscribe. Thank you very much, all the very best. Thank you. May God bless you.